Good morning, everyone. I'm delighted today to introduce and welcome our own fabulous faculty here at the University of Minnesota. We have 4 of our critical care docs, 2 PICU docs, Dr. Tina Slusher and Dr. Andrew Wu, and 2 of our neonatologists, Dr. Ellen Diego and Dr. Ann White, who will be presenting their academic work while they're away from home. So we're focused on global critical care today. I also want to welcome Dr. Professor Mark Okolo from Nigeria. We're so pleased to have him this morning. And just a footnote, Dr. Slusher is giving 2 grand rounds this morning. So Dr. Katie Satrom will be filling in for her. She and Katie work together on many of Dr. Slusher's projects. So Katie will take over to help answer any questions. And with that, I'm going to hand it over to Dr. Slusher. Thank you.
All right, next. We had grant funding from the Thrasher Research Foundation and from the Pediatric Device Innovation Consortium, and we have small royalties from the book Pediatric Procedure Pearls, which we're turning back to global health. And we will discuss off-label use of supplies used in pediatric device adaptations next. Our objectives are to learn about what our pediatric and neonatal critical care faculty are doing globally, address gaps in survival for acute bilirubin encephalopathy, neonatal sepsis, and respiratory failure, and finally, to identify ways of improving survival for neonates and young children in resource-limited settings. Next. Over 34 years ago now, myself and my colleagues started to ask questions about severe neonatal jaundice, and we have been working on the answers since that time. Collaborations have grown and strengthened and now involve colleagues from around the world, with the largest group in sub-Saharan Africa, especially and importantly, Nigeria, located in West Africa and the most populous nation in sub-Saharan Africa. Many of the recent projects have been done collaboratively with the now renamed Stop Kernicterus and Infection in northern Nigeria. Next. In 2017, we published our first systematic review and meta-analysis to assess the global burden of severe neonatal jaundice using clinical markers, including acute bilirubin encephalopathy, exchange transfusion, jaundice-related death, as accurate or even available bilirubin measures are often lacking. It was a population-based study with 76% of the articles, unfortunately, coming from high-income countries. In order to get a better representation of our low middle-income country partners, we went back to the drawing board, this time doing a systematic review and meta-analysis to look at the global prevalence of severe neonatal jaundice, again, using clinical markers among hospital admissions. We once again reported the data by the World Health Organization regions. We had articles from 1997 to 2020. We had over 2 million neonatal admissions, and about 6,000 of those neonates had severe neonatal jaundice. Unfortunately, Africa and Southeast Asia, again, had the greatest burden of disease for severe neonatal jaundice. Recent data from our own group and others suggest that jaundice is among the top 5 causes of neonatal mortality worldwide. Next. Focusing on one of our partner sites, Lagos University Teaching Hospital in southern Nigeria, Dr. Satrom and I helped them analyze their mortality data from their almost 3,000 neonatal admissions between 2018 and 2020, where we found an astonishing 12% of the neonatal death attributed to neonatal jaundice. Dr. Badayo, one of our pediatric residents, is helping Aminu Kano Teaching Hospital in Kano in northern Nigeria analyze their mortality data, and their results are almost identical to these of Luth. Next. As we have attempted to tackle the burden of disease from jaundice, we have and are continuing to develop a package approach to the problem. We have discovered that one extremely important piece of the package is maternal education. In our study, maternal education led to a drop in acute bilirubin encephalopathy from almost 30% to about 1%. Next. Additionally, we have found that education of healthcare providers is important as well. Among the many educational resources we have been a part of to include Sugar Pearls, a free online resource with one module teaching about how to do an exchange transfusion with supplies available in low middle income countries. And the other, a book which Dr. Bjorklund Loudon, one of our former global chiefs, and I had the privilege of editing and helping to write, along with many colleagues from the University of Minnesota and around the world, which added how to make low-cost, highly effective electrophototherapy to how to do an exchange transfusion, along with a multitude of other procedural adaptations for low resource settings. Next. Next slide. Another piece of the package is developing accurate, rapid measures of bilirubin. Our team has worked with others on the BiliStick ICTO test, and are piloting a phone camera app in addition to highlighting the work of others in this field in our publications, as the optimal point of care bilirubin device is not yet out there. Next. Hot off the press is this paper where we looked at a variety of measures to help understand and predict which neonates will go on to develop both acute bilirubin encephalopathy and the chronic sequelae kernicterus spectrum disorder. Understanding this is another important piece of the package. Included in those measures were the bilirubin-induced neurological dysfunction score, audio-evoked brainstem response, and MRI findings. Next. Since the early years, we have focused a lot of work on another important piece of the package, G6PD deficiency, which remains the single most important cause of severe neonatal jaundice in sub-Saharan Africa. Our work, both previously and ongoing, looks at aspects including screening, genomics, triggers of hemolysis, and other important pieces of this disease. Next. Effective phototherapy is obviously critical in treating jaundice. As most of you know, filtered sunlight phototherapy developed for locales with limited or no electricity and few healthcare workers has been shown to be non-inferior to both conventional and intensive phototherapy in the treatment of neonatal jaundice. Wide-scale implementation has been limited by several barriers, including the lack of a way for mothers to determine whether their baby has become too cold or hot under filtered sunlight phototherapy and needs to take a brief break. Working with a team of young learners from both sides of the waters, we are evaluating a liquid crystal thermometer device to determine if it is this missing piece. As you have hopefully noticed in our previous work, as well as this one, our team includes a lot of young learners from both sides of the waters. And we are all excited to have Dr. Nadia Samaguda join us and teach us how to scale and implement this important piece of our package. Next to my filtered sunlight phototherapy New England Journal of Medicine article, this article is likely the one I am most proud of, written together with my mentor, Professor Owa, and my mentee, Professor Abdulakar. We highlight and congratulate the AAP for stressing that American guidelines are just that, American, and continue to stress that each country needs their own guidelines, a critical piece of the package based on their local risk and resources. Next. Finally, I am sitting on pins and needles as I wait for SKIN to analyze and write up the results of the study to tell us the stories of these children regarding the challenges and successes of those living with kernicterus spectrum disorder in Nigeria. It will be powerful and moving. But while you are waiting for our Nigerian stories, please look at the link below as Dr. Vinod Bhutani, Stanford University, the parents of children with kernicterus and their children and young adults tell us their stories from a high-income country point of view. Imagine the stories from a low-middle income country as you do. You will be touched, and we hope moved to action to prevent this preventable tragedy. Thank you, and with that, I will turn it over to Dr. Ann White to discuss sepsis, one of the other causes of severe neonatal jaundice. Thank you.
Thank you, Dr. Slusher, for the introduction. I'm Ann White. I am assistant professor in the Division of Neonatology here at University of Minnesota, and I am passionate about decreasing neonatal morbidity and mortality around the world due to infections. And we know that here in the United States, in Minnesota, in high-income countries around the world, there are challenges in the prevention, diagnosis, and management of newborns sick with infections. And these challenges are really magnified in resource-constrained settings around the world. I had the pleasure of traveling to Nigeria in June of this year to meet with colleagues there who are interested in starting to address this problem locally. Next slide, please. So infections are one of the leading causes of neonatal death around the world, along with being born preterm or low birth weight, that is less than 2.5 kilograms, perinatal events, including things like hypoxic ischemic injury, as well as congenital birth defects. And if there was a fifth item on this list, there's very well evidence provided by Dr. Slusher that it could be neonatal jaundice, as she's just presented. And we know that infections are one of the etiologies of jaundice. Next slide, please. So this map by UNICEF shows 2021 data about the differences in neonatal mortality around the world. And the darker green colors indicate an increased prevalence of neonatal mortality. And we see that the heaviest burden of this issue falls in sub-Saharan Africa, as well as parts of Southeast Asia. Next slide, please. So we know that infections are a huge problem for neonates, that hundreds of thousands of babies around the world die from infections every year. And some factors that contribute to this high mortality in low resource settings include under-recognition of illness. In many locations, families will commonly take their sick newborn to a traditional healer first, and only if that treatment does not help improve their baby will they seek other care, sometimes leading to delays. We know that there can be a lack of access in some of these communities to facilities that are able to accurately diagnose and manage sick babies, as well as providers who are trained in pediatrics, who are able to recognize illness in these babies and when they may need additional referral of care. We know that just getting to some of these clinics for families can be challenging, that it may mean a long walk with a sick baby strapped to their back, or waiting for transportation on bumpy, dusty roads. And as I mentioned, at these facilities, whether it be either a community site, a small clinic, or a hospital, referral hospital, there is often a lack of laboratory capacity to accurately diagnose infections. There is not the technology to run blood cultures, and if blood cultures are done in the traditional manner, sometimes it can take up to 8 to 10 days for results to come from those, which is not so helpful, as we know, when we have an acutely ill baby. And then finally, these challenges in diagnosis of infection, it can lead to providers prescribing some antibiotic for a child for some period of time, but this practice can be inconsistent, and this is leading to the ever increasing and terrifying problem of antibiotic resistance. One of the factors not on this list, but that I've previously done a lot of work with, is infection prevention. We know that infection prevention is challenging here in the US, in Minnesota, that hand hygiene practices for providers are consistently audited, and there's room for improvement. And in places where there is limitation in the availability of clean filtered water, where there's not consistent electricity to be able to sterilize by autoclave equipment that needs to be reused, that infection prevention can also be difficult and contribute to mortality. Next slide, please. So this is one study demonstrating epidemiology, a review done by epidemiology in low resource settings. This review was done by Zaidi et al. And in this review, they sought to describe the bacterial etiology of community acquired infections in neonates. And so they looked at hospital data of babies who were diagnosed with early onset sepsis, babies who were admitted from home with a diagnosis of sepsis, or babies who were born at home and then admitted to the hospital and diagnosed with sepsis. And so what they found really was a high prevalence of gram-negative infections, including Klebsiella and E. coli, as well as Staph aureus, as kind of the top 3 etiologic agents. And I highlighted group B strep here because we know that group B strep is so prevalent in our country that we routinely screen, we give mothers prophylaxis. But as you see here, there's quite a range of variability around the world for prevalence of GBS. And certainly more studies are still needed to better understand this problem. But in many countries outside the US, GBS screening is not routinely done, or prophylaxis administered to mothers, because it has not been demonstrated to be such a problem. Next slide, please. Then we delve a little bit into antimicrobial resistance. So in this review by Thaver et al., they sought to better describe the antimicrobial resistance of bacterial infections acquired in the community by babies. And of their top 3 pathogens identified, Klebsiella, E. coli, and Staph aureus, there was 72% resistance to ampicillin. And as you can see here, with E. coli and Klebsiella, there's also resistance to 3rd-generation cephalosporins, as well as gentamicin. For Staph aureus, the methicillin resistance was rare, but they did have growing resistance to cotrimoxazole, which other name for that would be Bactrim. And this information is all very concerning in light of the fact that the World Health Organization currently recommends ampicillin and gentamicin as the rule out sepsis antibiotics for neonates. And with this growing resistance, we know that some of these babies will not be receiving any benefit from ampicillin and gentamicin if they truly are septic. And this problem is so bad already in some parts of the world that, for example, at the National Hospital in Abuja, the capital of Nigeria, they have moved to using meropenem and aztreonam as their initial rule-out antibiotics for neonatal sepsis because the antimicrobial resistance is already so significant. Next slide. And in this other study by the Neonatal Antimicrobial Research Network, they sent surveys to other hospital facilities within their network, asking questions about antimicrobial resistance. And we can see that in some communities, we're also seeing very high resistance already to third-generation cephalosporins, as well as even carbapenems. So we know that this is a real problem, and there's a lot of room for improvement. Next slide. And so that leads me back to our trip to Nigeria in June. And Dr. Slusher alluded to the SKIN working group. This group has been working in Nigeria for over 30 years on problems of jaundice, as she mentioned. And with the growing interest in addressing infections, we kind of tagged along with this group. And so we have modified SKIN to stop kernicterus and infections in northern Nigeria. Now, in Nigeria, the neonatal mortality rate stated there's about 39 per 1,000 live births, as opposed to about 5 to 6 in the United States. And from previous epidemiologic studies, we know that tens of thousands of neonatal deaths every year are attributed to sepsis. And as I mentioned, there are challenges in evaluating these babies and determining if they really are septic from lack of lab infrastructure and with lack of cultures and other diagnostic tests to really help us make this decision, this diagnosis, which can lead to inconsistent treatment of sepsis. Next slide. So just as a reminder, Nigeria is there on the world map highlighted in red. It's a country in West Africa. And I mentioned Abuja, that's the capital there in the center of the country. And in June, we spent most of our time in Jos, which is labeled there on the map, northeast of Abuja a little bit. We did also visit Kano up in the north, as well as Lagos for a few days. Next slide. This is Jos University Teaching Hospital, our primary partner site for our current sepsis work. Jos is in a plateau state, and it's just beautiful. So it was wonderful to be there. Next slide. These are some members of our research team. So from the University of Minnesota, there is myself, Dr. Tina Slusher, critical care doctor, and Dr. Beth Thielen, MedPeds trained in infectious disease. On the Nigerian side, we have many different members of this group, including pediatricians, laboratory doctors, and infectious disease experts. And as Dr. Cindy Howard mentioned, we do have Professor Marco Colo with us this morning, representing the Nigerian side of our team. Next slide. So our current working aims for our project are, one, to measure the frequency and antimicrobial sensitivity patterns of culture-confirmed bacterial and fungal bloodstream infections in neonates with suspected sepsis. And we are interested in starting with, we know, a baseline about kind of the updated epidemiology. We are planning to use the BACTEC machine that is present at Juth University Teaching Hospital to perform the cultures. Our second working aim is to correlate laboratory performed point of care C-reactive protein and procalcitonin measurements with our culture findings. And our plan is to test these at 12 and 24 hours after admission of the babies with suspected sepsis. And the real goal of this aim is to see if there is enough of a correlation with the positive cultures with the sick babies to possibly be able to use these tests, especially the point of care, out in more rural and remote areas to help guide decisions about starting antibiotics, continuing antibiotics for babies. And we know these tests are not perfect, but we, at this point, feel that compared to kind of what we have with nothing in some of these communities, and the providers trying their best with history and a physical exam, that these tools could potentially be useful. And then our last aim is to incorporate some next generation sequencing technology. Specifically, we've talked about using the Oxford Nanopore instrument and using this instrument to diagnose bacterial, fungal infections, as well as viruses. As we know that there have not been many epidemiological studies done really looking for viruses as a cause of newborn illness. Next slide. And so, as I mentioned in this slide previously, really, we're hopeful that some of these innovative tools, including point-of-care biomarkers, as well as metagenomics, can improve timeliness of diagnosis of infections for babies in resource-constrained settings. We believe this is likely to improve neonatal morbidity and mortality, improve antibiotic stewardship, and reduce these growing rates of antibiotic resistance, and also help standardize some of the management of sick babies. We know that we can improve diagnosis of infection, use antibiotics when they're indicated, hold off on antibiotics when they are not needed. It will also improve cost effectiveness for families, often who are paying for hospital stays, for medicines for their babies, and making difficult decisions about continuing medicines versus buying food and providing food for some of their other children. And overall, we believe if some of the findings from this study are positive, that they will be scalable to other countries in low middle income settings. So our next steps at this point are to continue our protocol planning to look for funding, and we do have committees that we have divided up to assign all of this work. So we are still in planning stages, but there is a lot of enthusiasm to move forward. So at this time, I will hand it over to Dr. Ellen Diego.
Hi, everyone. Thank you, Anne, and thank you, Tina, so much for setting me up for now my overview of some of the research that I'm doing. So I'm also one of our members of the neonatal perinatal medicine. I'm relatively new faculty here. And today I'm going to be describing the way that I work with local health facilities in low and middle income countries to help them identify gaps in adherence to what is called essential newborn care practices around the time of birth. So we see that infants really disproportionately are dying in the early first hours, even days of life. We see that 75% of all infants who are dying in the first 28 days of life are dying in the first 7 days, actually. And when you zoom in and focus, you see that about 25% are passing away in the first 24 hours, which really shows us that that essential care package that's delivered in those first critical hours of life are so vital to helping these infants survive. We know that infection, of course, is another cause, but when you look over here on the side of the slide, you can see that preterm birth complications and failure to establish effective respiratory effort in the first minutes of life, or birth asphyxia, are the two other leading causes of death in the care of the patients that I take care of in the early days of life. So what is essential newborn care? So when we say essential newborn care, or E&C, which you'll hear me say throughout this talk, we're really describing a bundle of care, which includes basic resuscitation, so establishing effective positive pressure ventilation for infants who are not breathing in the first 60 seconds of life, and following them through the first early hours of life with good supportive respiratory care. hygiene practices, which Anne beautifully outlined, nutritional support with early and exclusive breastfeeding, and thermal regulation in the first hours of life. Why it's so important to deliver this care package is that we see improved survival and improved growth and development in the early days of life if we adhere and have facilities adhere to these essential newborn care practices. And so when we think about ways to improve outcomes for infants, of course, we think about, well, we need to train our providers, our birth attendants, and our midwives who are going to be attending deliveries in essential newborn care practices. And so back in 2010, the American Academy of Pediatrics teamed up to really form a curriculum that was suited and appropriate for low and middle income countries, essentially the equivalent of NRP in our country, high income countries, that is adapted to resources in different environments throughout the world. And so this training package was released and trained providers, over 1 million providers throughout the world in over 80 countries. But what they found with a decade and some change of research is that when this curriculum is implemented but not successfully transitioned into the actual facility, we see that those sustainable improvements in neonatal mortality are just not happening because providers are losing their skills that they're practicing in the classroom and in the curriculum training. And then in addition to that, if the curriculum is not adapted to the local health facility gaps and needs, then the curriculum is not successful. And so back in 2022, they started to revise this curriculum. The World Health Organization joined in with the AAP and created a new version called Essential Newborn Care 1 and 2 to really address how facilities can integrate quality improvement research to be able to improve and sustain the benefits of this curriculum being implemented worldwide. So, what is it that I actually do when I go into countries? So, in addition to actually training providers in the Essential Newborn Care training course, I also help them go through their facilities and look to see where in their hospital workflow are they not adhering to the essential newborn care practices. Sometimes it's that there are equipment barriers that prevent effective suctioning or positive pressure ventilation because they don't have an appropriate mask size. Sometimes it's that the providers haven't been re-updated or practicing their skills, and so they're unable to improve ventilation for infants who are struggling to breathe at birth. And sometimes it's systems-based barriers that prevent effective curriculum implementation. And so I thought the best way to kind of share with you how I do this when I go in country is by using an example. And so we'll talk specifically about some of the work that I've done this past year in Somaliland. So I've included a map here you can see. So when I say Somaliland, I think people are initially confused because they think I'm talking about Somalia. But Somaliland is actually a republic that broke away in this northern region, most of this darker green zone here, that broke away from Somalia after a civil war back in the 1990s, and is geographically isolated from the lower part of the country, which is Somalia. And so the first institution of higher education that was formed in Somaliland after it broke away as its own republic that is technically not internationally recognized, the Mood University was established, and there is one subspecialty training program in the country, which is in family medicine. So the family medicine docs who have been trained were trained in 2012, noticed that a high number of patients that were dying in their healthcare facility were newborns. And so they wanted to address this gap by establishing a NICU, which they did back in 2017. And they noticed that they really just did not have enough training, being in family medicine, they're taking care of the whole life spectrum. And they really wanted to have some focused education from neonatal specialists from the United States, myself included, in essential newborn care and for the care of small babies. And so I was able to establish a relationship with them last summer and travel again this past summer with one of our amazing medical students, Priya Kanajam, and also Megan O'Neill, who's one of our neonatal nurse practitioners. So the first thing we do when we travel to new sites is we get to know the people that we're training. So this is a face sheet that includes the family medicine resident physicians who participated in our essential newborn care training package, as well as the neonatal ICU bedside nurses, as well as the maternity staff. So we took them through the course. We trained them in essential newborn care 1 and 2. So we do pre-assessments with multiple choice tests, take them through ENC simulation training, and then to be able to pass the course, they take an OSCE exam to prove that the skills that they acquired in the classroom, they're able to replicate in a simulation environment. So these are some photos of our family medicine staff and family medicine and NICU nurses and maternity staff who are going through the ENC 1 and 2 training in Somalia. And in addition to training in ENC, we also implemented, thanks to the wonderful advice and counseling from Dr. Ann White, instruction and education in infection prevention and equipment reprocessing, because a lot of the tools that we need to resuscitate babies, we need to make sure is free of infection, not just present, but also ready for use in terms of disinfection. And so we also train after the course in infection prevention and how hospital systems can establish effective means to be able to disinfect their equipment. And then, of course, the piece de resistance, the final part, is quality improvement. So we train all of the participants in basic steps of quality improvement so that they can be able to assess their learning environment and their hospital environment to identify gaps where the standard of care that is recommended worldwide is not actually being adhered to in their local facility. Then we go through the process of coming up with ideas to make changes to be able to close those gaps in outcomes for infants. And so the way that we then train them is to be able to manage their data and track their outcomes to show that the changes that they're implementing to try and close those gaps are in fact leading to improvement in care. So here is my 7 steps for quality improvement, which everyone received training in. Really going through and doing clinical observations in the unit. We follow the students, we follow the residents and the nurses into the unit and observe them at deliveries, babies being born. We follow them through NICU admission, and we look to say, where are we not adhering to best practice standards? And so what we noticed in our observations is that babies were not being started on early effective positive pressure ventilation for those infants who were in respiratory distress at birth. And this was leading to a significant portion of infants who were having long-term morbidity and mortality related to these gaps. And so we assessed the current practices around positive pressure ventilation delivery, and we noticed that there were a number of barriers to effective positive pressure ventilation. So we saw that there were challenges with the patient interface. There was no standardized respiratory assessment, no ability to blend oxygen, and that the equipment was not being properly disinfected and the air was not being effectively humidified, which were causing significant barriers to effective non-invasive ventilation delivery. And so after our QI workshop, the students and the residents got together as their multidisciplinary team to decide how they wanted to improve the delivery of CPAP in their unit. And so they put together their SMART aim, which was to improve respiratory distress by increasing effective CPAP for all neonates less than 30 days, admitted to the Barama Regional Hospital from 45%, which was their baseline data, up to 90% by December 31st. And a huge area of focus was to develop a clinical protocol to really streamline respiratory assessment, identify babies who needed CPAP, and to be able to make sure that the CPAP that they were delivering was optimized in terms of how the equipment was being set up and monitored by the bedside staff. And so here are some photos of our CPAP skills training workshops that we conducted after we went through the motions of putting together our QI project. And you can see our training staff from the United States training a variety of providers and a lot of our residents who are putting together and troubleshooting the optimized homegrown CPAP device that they developed. And our medical student Priya put together the most beautiful posters that are now officially printed and posted in the neonatal ICU to be able to make sure that even long after we are gone, that they are able to see how the device should be set up and disinfected every single time it is used in the unit. And of course, we put together the clinical protocol that was based on our quality improvement project and multidisciplinary work group. And so this protocol went live on August 16th, and we are actively collecting data. We'll be actually meeting with our group next week to see how our first PDSA cycle is going and gather information about how we can optimize our outcomes for our patients. And just a last little plug that, of course, anytime you're doing QI in facilities, it's always very helpful to make sure that the metrics that you are following and the quality indicators that you are tracking are based in evidence and linked with quality. And so one of the things that I've done this past couple of years is to develop a menu or a directory of quality indicators that can be used to really demonstrate and show and track essential newborn care outcomes in low resource countries. So this is available, was just published in the Journal of Pediatrics this past month. So I'm very excited about this, to get this out into the hands, and just a huge thank you to Dr. Neglia and the department for funding the support so that this publication could in fact be open access, so that people who do not have subscriptions to some of the medical journals in high income countries are able to access this information. So a huge thank you to the department for supporting us financially. And I will now turn it over.
Hey everyone, my name is Andrew. I'm one of the new PICU faculty at Hennepin. I did residency here, so some of you may recognize me from 3 or 4 years ago. So this is a little bit continuing kind of on our flow, as Ellen was talking about. Something they used over there was CPAP. And so I'll be talking about a singular study that I have been working on in Cambodia that focused on blending oxygen for low-cost bubble CPAP circuits. Next click. So this is a pie chart from the Global Burden of Disease study in the Lancet, which some of you may be familiar with. And this reflects the cause of mortality in children under 5 from around the world. And as you guys can see, pneumonia at the top there accounts for a large portion of the pie chart. Next click. And if you look at the geographic distribution of those deaths from pneumonia, they're mostly in sub-Saharan Africa and Southeast Asia. Next click. In case you didn't know where Cambodia is, it is in Southeast Asia. This is a picture of the country itself. Next click. I was in the town of Kratie, which is circled in red there, which is the capital of Kratie province, which is one of the 4 eastern provinces of Cambodia, which are reputably known as kind of the 4 most rural, or basically the most rural section of the country, those 4 provinces. And the under 5 mortality of the country is about 30 out of every 1,000 live births, as opposed to 5 in the US. Next click. This is just a picture of what kind of the town of Kratie looks like right outside of Kratie proper. Next click. As far as the hospital that I worked at in Kratie, the name of it is Chenla Children's Healthcare. And on the left there are Bill and Lori Houseworth. They are 2 US trained and med-peds physicians who have lived in Cambodia for over the past 15 years or so with their 4 kids. And they have built up this hospital, and it is currently expanding. It's about 5-6 years old and has a full NICU, PICU, inpatient, outpatient, and they're really moving mountains over there. So I've been working with that group since 2018. Next click. So that was when I did my first visit, and I had some subsequent visits after that. Next click. In 2018, I did present at that Grand Rounds at the time about a brief chart review that I did in that hospital. And what I essentially found is that the hospital population there is no exception to the large burden of pneumonia that affects the entire, or affects kids under 5 around the world. Next click. And so moving into basically to bubble CPAP and the treatment of pneumonia. Many of you are familiar with these pictures, right? So you have conventional CPAP, which is the pressure in that device is, controlled by a valve that is controlled there by a computer chip. And then you have bubble CPAP, which generates pressure from the physical interface between the air and the water in the expiratory chamber on the left side of that picture. Next click. So as many of you know, bubble CPAP has shown to be very effective in neonates, not only in high resource settings, however, but also in low and middle income countries. And because it is much less expensive than conventional CPAP, it is a very popular option for providers working in low resource settings. Next click. So much so that the WHO, World Health Organization, in their book, Oxygen Therapy for Children, also promotes using bubble CPAP for neonates and small children. However, as you might imagine, bubble CPAP, the conventional version as shown here, can still be prohibitively expensive in low resource settings. And so in those settings, next click, the WHO book also promotes this low cost, do it yourself DIY bubble CPAP, which some of you may be familiar with if you've worked with Dr. Slusher in some of her workshops. If you're not familiar with it, it is essentially made out of a nasal cannula with some strategic cuts from scissors and some taping and a bottle of clean water and an oxygen source, which is usually either an oxygen tank so 100% oxygen, or an oxygen concentrator, which then you need reliable electricity to use. But other than that, it is very low cost and is also shown to have some efficacy. Next click. So as I mentioned before, I've been working on the oxygen blending piece. As I mentioned just now, DIY bubble CPAP often runs off of oxygen tanks, which therefore means that it runs off of 100% pure oxygen, which we know is not great for neonates. Next click. It's also well known in adult literature that hyperoxia is not great, but only recently has it been shown that hyperoxia is also not great for critically ill children. So in general, hyperoxia is just not good in general. Next click. So what we were trying to develop is there a DIY low-cost way to blend oxygen for this DIY low-cost bubble CPAP circuit? So fast forward about a year or two, next click, and we come up with this device here. What it essentially is it works like a Venturi blender where you have oxygen gas come into a syringe housing that has a 22 gauge needle in it, which then protrudes into an oxygen tubing with a strategically cut entrainment port. It essentially sucks in room air into the 100% oxygen jet stream and then dilutes it and gives you blended oxygen and room air. Next click. We've recently dubbed this the low cost entrainment syringe system or less O2 blender. Next click. We published the development of the blender in the Journal of Mechanical Engineering in 2020. Next click. And then we also published findings from workshops that we conducted both in the US and in low resource settings, teaching new users how to build and use the device. And essentially what we found is that after the first attempt, it takes about 14 to 15 minutes to make. Next click. So what I've been working on over the past few years is the safety and feasibility of this trial in the clinical setting. At Chenla Children's, we took children who were admitted with pneumonia, placed them on the low-cost bubble CPAP circuit without the blender, stabilized them for 2 hours, and then swapped them to our blender circuit and watched for clinical failure within the hour. Next click. We did training for this study in early 2020, and then I presented the experience in the following Global Health Grand Rounds. Next click. And these are just some pictures from the experience. Next click. After that, I went to PICU fellowship over on the East Coast, New England. Next click. Of course, with all of this going on, this was the height of COVID happening. Next click. And so I did not actually start the study until the middle of fellowship. So there was a bit of delay. And due to the pandemic, they also increased their nursing staff group. Next click. And Dr. Slusher generously donated her time to go over there while I was in fellowship and retrain the nurses on the study protocol. And there were definitely more nurses this time around. Next click. So this is a picture of the entire circuit that we implemented in the study. You'll see there's a nasal seal adaptation, which I won't go into for the sake of time. Next click. But these are snapshots from the study of the nurses building and using the circuit with the patients. Next click. Ultimately, what happened is that we enrolled 33 patients over the year. One patient withdrew due to parent requests, and the other 32 were placed on a low cost on the blender circuit. One met clinical criteria for failure, but the other 31 eventually were discharged home in good condition, and we deemed this safe to use. Next click. The patients who we enrolled were under 4 months of age. Most of them were term, and most of them presented in moderate respiratory distress, according to the TAL score. Next click. A little more than half experienced at least one adverse event associated with the circuit. Most of the time or about half the time, that was associated with loss of CPAP. So either intermittent bubbling or loss of bubbling. And about 20 to 30% of the patients required at least one repair or replacement of the blender circuit. Next click. As far as the FiO2s that we were able to achieve at the nasal prongs, you'll see that most of the time it was between 40 and 60% FiO2. as measured by an oxygen sensor, depending on what blank port size they use for the entrainment port. Next click. At the end of the study, which was actually earlier this year, myself and Dr. Gwen Fisher, one of the PICU faculty at the University of Minnesota, both of us went over to Cambodia, basically celebrated the end of the study. Next click. Cambodians really know how to party. We did it on a boat, which was not planned. But we also gave them certificates saying that they are now pros at making the circuit. Next click. Oh, next click again. Thank you. As far as next steps, during the study, we conducted an informal nursing survey asking about the experience, which was overall positive. They all did suggest to make the oxygen tubing more flexible. You can see from the picture here that the circuit requires the grafting of nasal prongs onto large oxygen tubing, which increases the ability to provide pressure, but decreases the flexibility of the tube. So we have an engineer working on the Gen 2 version of this device, and also hope to host workshops in the future and publish a manuscript on our findings. Next click. As far as lessons that I'm learning about this, essentially conducting international research with multiple IRBs during fellowship is very difficult, but also very doable. And then for the sake of time, I'll jump to the last bullet, basically saying that investment in a singular community, I think, is incredibly rewarding for both sides of the party. I've always admired those with multiple relationships across the world, but I find that the friendships and the relationships that I've developed in Cambodia are what really drives me to go back. Next click. I'd like to thank Chenla Children's first and foremost for always welcoming us back and being so warm and generous with their time and their resources. And then the Pediatric Device Innovation Consortium for their funding for this study. And of course, everybody with the Global Pediatrics Program for their support, whether I am in Minnesota or away. Thank you.
Thank you so much, Dr. Wu and Dr. Diego, Dr. White, and Dr. Slusher. I'm always amazed, though I know quite a bit about what you're doing. I'm always amazed to have an update. So thank you so very much, and we'll open up to any questions anyone might have.
Many of you, I always like to just jump in with my own questions, but many of you are employing quality improvement tactics to your work, or implementation science, I suppose, the new thing that I'm learning about. I always think about, bringing the things we're doing other places back home too, and just would be curious to hear your reflections on trying to do projects with our residents here at home, and how you can take some of the lessons you've learned doing projects abroad and apply them to doing projects here in our own programs and clinics and hospitals.
I can start by grabbing that one, since this afternoon from 1:30 to 3:30, I'll be teaching the fellows, all of the fellows, quality improvement, where I teach the core curriculum for our fellows. But in addition to that, obviously all trainees, the 7 steps to QI that I teach and train in low resource countries are actually the exact same steps that I use to train in the program here, because I think there are so many sort of translations between high and low income countries, and learning those basic steps of QI. I mean, obviously your data management might be different, the scope of the project might be different, the resources available might be different, but why I think QI specifically lends so well to being implemented in low resource countries, and why the skills that our residents, our fellows, our medical students are learning here in the States can really directly apply abroad, is that you can see it happening in real time. QI is very much obviously a rigorous type of research, but it doesn't require quite as many sort of developmental and financial supports. And so it's really real-time assessment of data and real-time adaptation. So I think it's a great skill to learn. And as we in the high income countries are starting to rely on quality outcomes to drive financing and support in our hospital systems, it's going to be something that every single person in their early career and throughout their career are going to have to rely on, because hospitals are starting to look for that, which is we want to make sure that the dollars that we are spending are equaling better outcomes for patients, for payers, for all of the people involved in the healthcare system. So I've definitely drunk the quality improvement Kool-Aid.
And Emily, I would add that hopefully we have a number of our residents watching today, and we would love to involve them in the research that our faculty is doing. It's sustainable, and we certainly seek to be equitable with our global partners. Probably many folks saw that we are publishing with our partners, and we are very much committed to always having our at least the first and or the last author to be one of our colleagues in another part of the world, and we're also committed to open access, so that we can share what we learn together with folks everywhere.
It looks like we have a question in the Q&A. In patients who usually take their children to local healers, has training the healers to recognize patient conditions changed referral patterns to medical care?
That's a great question. And I would say, Professor Okolo, if you would be willing to maybe contribute, I think he will have much more experience and being able to address that. And I would just say there are definitely efforts. So the World Health Organization has identified several neonatal danger signs that include jaundice, poor feeding, movements that would be concerning for seizures, fever, temperature, instability. But exactly how all of that works with traditional healers, I am not as familiar with. If Dr. Okolo would comment, yes.
Okay, thank you very much. Mark Okolo from Jos, Nigeria. For stability of the data network, I will have to go with just the audio. Suffice to say that in Nigeria, traditional birth attendants are a menace. Well, actually, they are meant to save lives, but at the end of the day, they are a problem to the management of neonates. Some of these pregnant women end up in traditional birth homes and remain in those birth homes for 3 to 4 days and end up with all kinds of complications before they present in the hospital. And so traditional birth attendants have been a lot of issue in the country. Health education and training and retraining is ongoing to ensure that they transfer pregnant women in their traditional birth homes on time to the closest hospital for care. And I would like to say that the discussion by Ellen Diego on the quality indicators for essential newborn care is also very important. I think we may have to introduce this in our routine discussions in the hospital, looking at the outcome indicators, the process indicators, as well as educational indicators. This will actually play an important role. Every healthcare professional has a role to play. And so we will ensure that this is stepped down to our healthcare facility to ensure that new pregnant women present on time to the hospital, particularly from traditional birth homes, and then discourage home deliveries, which is becoming a problem in the hospital, probably because of cost of healthcare. And this will help to improve deliveries in our centers and in our country in general. Thank you.
We have a comment from Dr. Stephen Guche in Nigeria. he says, "Hi all, thank you so much for the presentation. How could we in our setting be part of the development of this initiative? I imagine the cost would be better tolerated looking at cost of oxygen here and now." That may be a question for Andrew.
It's so, Dr. Oguche, if I think what we're doing right now is essentially spreading the word about the device. The less O2 blender, based on the data that we have so far, we have found to be safe. I will say that the caveat to it is that in our study, we found that initially when we started the study, the hospital only had a few bubble CPAP machines, but by the end of it, they had like over 15 or so. And so our recruitment went down, which is really great for them, right? Because then they have machines that with larger tubing and things like that. So I think the reason why I bring that up is because I think we would love to share, excuse me, we would love to share the device to wherever we feel like will be applicable. But I also want to make sure that the less O2 blender is not taking the place of technology that is of higher tier. But I think that with that said, if a site is already using improvised bubble CPAP, like what WHO promotes, then I think that the blender can be a value add for the patients for that site. So maybe my email is there on the slide there. I'd be really happy to talk with you by email about how we can try to get things going over at where you're working.
If it's okay to do one last shameless plug for Ann and I know we're out of time here, especially just Emily, to speak to your training. We actually have hosted this past summer 2 training courses in essential newborn care, the training curriculum. And I think that's a great way for any interested medical students and residents. We actually had a few of our residents and medical students join the first couple pilot courses, but we will be hopefully offering this maybe twice a year is our goal. So anyone interested in receiving training before they depart for international electives, I think it'll give them a transferable skill that potentially will hopefully help really optimize their time in country. So that's another great option for people to get involved. So stay tuned. Hopefully we'll be publishing dates for our upcoming training session soon. We haven't settled on them yet, so stay tuned.
Wonderful. Thank you so much. What a just amazing lineup of presentations, and we're seeing international collaborations being formed before our very eyes. So thank you for all of the amazing work that all of you are doing. We are really lucky to have such superstars on our faculty. I hope everyone has a fantastic day. Reach out to these amazing global health faculty and learn more about the work that they are doing. And we will see you back here next week. Bye, everyone.